I'm Dr. Drew Howard, and welcome to our bariatric webinar where we're going to discuss some weight loss surgery today. Thank you for joining us. For some people, they like to look at my background. As you can see, I am board certified by the American Board of Surgery. I did my minimally invasive and bariatric fellowship specifically in weight loss surgery at the University of Florida. Before that, I was in Alabama and San Antonio for medical school prior to that, and of course undergraduate at Texas A&M University. Today we're going to talk about the problem of obesity, the surgical treatment for obesity, the outcomes of those surgical treatments, kind of what you can expect, and then next steps. There's a lot of hoops to jump through to get from here to there, but my office has done this many, many times, and we're here to help you every step along the way. So first we have to define obesity. Obesity is defined by BMI, or body mass index. That's just a height versus weight ratio. What you can see is if your BMI is over 30, you're considered obese, over 40, morbidly obese, and over 50, super morbid obesity. Here's a graph that shows height versus weight, and you can see anybody in that reddish-orange zone is BMI of 35 and over. Those are the people who qualify for their insurance company to pay for surgery. Others can qualify, but insurance company doesn't start to pick up the tab till the BMI is over 35. Here's kind of the trends we've had in the United States. What you can see is in 1990, about 10% of the patient population was obese or morbidly obese with a BMI of over 30. In 2000, it got up to roughly around 20-25% in some places. And then 2010, now we're, especially across the South, over 30% with people with a BMI of 30 or more. Obesity is a metabolic disease. It causes all of these medical problems that you can see this lady has, whether it's sleep apnea, high blood pressure, diabetes, reflux, arthritis, gallbladder problems, liver problems, all associated to obesity. In fact, obesity has become the second most preventable cause of death in the United States, secondly to smoking. And what you can see from this graph is as your BMI goes up, your mortality or your chances of dying in a single year go up. They can be almost 2 to 2.5 times greater than somebody who's normal weight. What are the causes of obesity? Well, it's kind of a three-headed monster. First, the obvious is the environment we live in. You can see Burger King and McDonald's, when they first came out with hamburgers and french fries, they were this size in the 50s. Now we call those Happy Meals, and you can supersize anything you want. Coke, Cola, 6.5 fluid ounces. Some of you may remember that. Now you can get a Route 44 as big of Coke as you want. All liquid calories going in. Then there's the genetic issue. We know, and we've seen from studies, if you take a adoptive child, his adult BMI will actually be closer to his genetic parents than it will be his adoptive parents. So we know that there's a genetic link to obesity. And then ghrelin. We know ghrelin is a hormone made in the fundus, which is the upper right portion of the screen when I show you a picture of the stomach. It is made there, and it tells you you're hungry. Ghrelin tends to spike 4 times a day, around 8 a.m., noon, 6 p.m., and midnight. Compare that to somebody at the bottom who's had a gastric bypass procedure or a sleeve gastrectomy where ghrelin has been removed. They don't get hungry. This is what the difference is between dieting and surgery. Surgery patients don't have hunger problems like dieting patients do. Now I know all patients, including yourself, have tried dieting. You've tried 1, 2, 3, or 5 of these different diets, and they've worked for a little while, but ultimately they failed, and you get frustrated because 6 months after you started a diet, you realize you've gained a couple of pounds more. The reason I know this is because the NIH back in the early 90s did a research study, and based on their research study, they concluded this statement, that once a person is severely obese with a BMI greater than 35, the likelihood they will lose enough weight by dietary means alone and remain at a BMI below 35 for a year or more is estimated at 3% or less. So the fact that you can't really get this weight off and you're struggling with it with diet and exercise means you're normal, means you're in 97% of everybody else. Which is why, based on that study and a bunch of others, the NIH came out with this statement, They said for patients who are morbidly obese, surgical intervention is the only method proven to have significant long-term impact on the disease. And they caveated it with when medical interventions have failed, which is why some of your insurance companies will require a medical evaluation period. The best medical weight loss, though, is surgery plus proper dieting plus behavior modifications plus exercise and then some psychological counseling. We want to put all of that together so we give you the best results, and that's what we do in our office. So, what are the surgical treatments for obesity? Well, first, the adjustable gastric band or the lap band, the sleeve gastrectomy, the Roux-en-Y gastric bypass, the duodenal switch, and newest on the market today, the gastric balloon, which I'll talk about in a minute. I'm not going to talk too much about that duodenal switch because it causes a lot of complications. And if you think that's the right one for you, come in, we can talk about it, but we only do it about 1% of the time. So the adjustable gastric band used to be very, very popular, but now has fallen out of favor because of a number of complications. But the way it works is we take this little band, put it around the top part of the stomach, and it creates a little blocking point there to where food comes down, dilates the top pouch, and then not until it's well digested, drops down. If you take too much food in, you end up throwing up. This is what we call a purely restrictive, meaning it restricts how much you can take in surgery. Some people like to say it's reversible. It's really not. It's removable, but it leaves a lot of scar tissue behind. And it's outpatient surgery. You have the surgery, you go home. That compared with, though it has some slow weight loss, it takes about 2 to 3 years to lose the weight. You only lose about 45 to 50% of excess body weight, so it's not as good a weight loss as the other couple operations. You have to come in for multiple clinic visits and adjustments. In fact, I have to access that port that you see with a needle each time. So if you don't like needles, this is not a good operation for you. It is a foreign object that we put in you, and some people react differently to that. And then all of these surgeries I do laparoscopically through small little incisions. This one I have to make a little bit bigger incisions because I got to put that port and that band in. The big problem we see with this is a slip. We know about 15% of people will slip in the first couple years. Slips are a problem because you can't get anything down, and the band is not working for you at that point. It's actually really working against you. Cause you to throw up constantly and have major problems, and can lead to an erosion in about 3% of people. This is a hole that the band has caused to actually eat through and erode through your stomach. We do see about 1 in 4 people will get pouch and esophageal dilation. That's where everything above that band gets pretty dilated. It leads to some pretty bad reflux in some patients. Um, Complication rate, like I said with this, about 15 to 20% of people are having some problems with their bands in the first 5 years. Then there's a sleeve gastrectomy, by far the most common operation that we do, and we've done a number of these. We do this through creating a thin stomach, which we call a sleeve of a stomach. It looks like a banana when we're done. You can eat about amount of the palm of your hand, and that's about it. Nothing more will fit in it. It is not reversible, but your excess weight loss, you'll lose about 65 to 75% of your excess body weight, meaning how much you will lose that you are overweight. Happens in about a year and a half. You stay in the hospital 1 night for this operation. People like this because there's no foreign body inside like the band. There's no dumping syndrome like the gastric bypass. No need for those adjustments and fills and needles. It's a one-stop, get the operation and start to see great results even starting the next day. Believe for patients who've had a BMI greater than 60, this is definitely by far the safest and best operation for them. It has the least amount of complications amongst all of these operations. The big complication we worry about the most is a leak. Leak is because that staple line that you see there can leak. I double and triple check this at the time of surgery, and then even the next day we get a leak test. We also put you on a post-operative diet that is very, very important for the next 6 weeks to make sure we don't stress your stomach. By doing all that, we ensure that we keep our leak rate nice and low and keep you safe. We also have to worry about vitamins in all of these. We will put you on vitamins before and after surgery so you can not get vitamin deficient in the long term. Some people are having some reflux after this operation. If you get reflux after a sleeve, it will go away within 6 months. Then there's a gastric bypass. The gastric bypass we've been doing for the longest. We started doing gastric bypass as an open procedure where we make a big incision in the 1960s. Now we do that all laparoscopically through small little incisions, but we're basically rerouting your intestines. By rerouting your intestines, we create a small pouch of a stomach so you can't take that much, but also the food doesn't actually meet all of the digestive enzymes that it needs till way further down the track. Once again, with this, you'll lose about 65 to 75% of excess body weight, and it'll happen in about a year and a half. This, just like the sleeve, you stay 1 night in the hospital, 2 days. The big concern with this is once again a leak. And once again, I do certain things to prevent this. As opposed to many other surgeons out there who just staple their pouch back together and staple things together, I actually sew and then over sew all of my pouches. What that does is it helps prevent leaks. We did this at the University of Florida, and we did 1,000 of these in a row without having a leak by doing it this way. So that takes the leak rate, the national leak rate, about 3%, down to much, much less than 1% for my patients. They can get a little swelling at where I'm sewing everything. So if that happens and you're one of the 1 in 30 or 40 that happens to, you'll have to stay in the hospital 1 or 2 days extra just to let the swelling go down. Mortality rate still very, very low for this operation. Complication rate also low at 10 to 15%. Dumping syndrome is a complication from this where you can get some extra diarrhea and extra bowel movements because things are moving through the process so fast. Internal hernias, because we've rerouted things, sometimes they want to twist up on themselves. You'll know if you have an internal hernia because you'll come into the ER with a lot of pain. They'll do a CT scan, and then they'll call me and say, hey, the patient has an internal hernia, and we'll have to go in and fix it. And then ulcers. Ulcers happen usually because you smoke. So one of my rules is no smoking because we can't afford ulcers in your stomach when you have a little stomach like a sleeve or a gastric bypass. Because if you get an ulcer, then we have to go out and cut out the rest of your stomach, which would leave you most likely on a liquid diet for the rest of your life. But if you don't smoke, ulcers go from 10% to less than 2%, and then we make it even less than that by putting you on a proton pump inhibitor medication for the rest of your life in the gastric bypass patients. So the gastric balloon is our newest procedure, and we are in North Houston, one of the few who have started doing this, but have pioneered the way. What we have for the gastric balloon is we use the dual balloon because we feel it's safer. There's no history of migration with the dual balloon, and it actually takes up more room in the stomach. By using the dual balloon, I put that into your stomach and blow each balloon up. They are connected, and they take up room in your stomach, and thus you cannot take that much food in because you feel full, and you feel full all the time. It's left in for 6 months. It's placed endoscopically all through your mouth and removed endoscopically all through your mouth. So no incisions with this operation, and it's done same day operation. So we put the balloon in, you go home about an hour after we're done. Does not have the weight loss that we see, especially with the sleeve and the bypass, but is great if you want just a temporary get rid of weight and then you plan to stay on that weight loss pattern for the next many months after that. So we remove it at 6 months, but we follow you monthly for a full year with the balloon in place. 6 months with it in and 6 months after to make sure you're on track. You also get a Fitbit, a scale, all that go into a computer program so we can follow you and track along with you. The big thing we see with the balloon in the first 3 to 5 days after surgery, you can have some pretty extreme nausea and bloating, even some vomiting. You'll get this for those first couple of days, and then once your body's used to the balloon and realizes it's there to stay, it goes back to better control. The problem with the balloon, one of the issues right now is it's not currently covered by insurance. It is FDA approved, but it is not covered by insurance. But we have a very competitive cash price, if this is something you're interested in, stop by the office and we'd be glad to talk to you about it. So some people are concerned about surgery and the risk of surgery. The big thing you have to remember is it's really risky to keep those medical problems. And there's a study by McGill University, and what they found was the 5-year mortality rate, meaning the number of people that died in the no surgery group, was over 6% at 5 years. In the surgery group, it was 0.68%. So, though there's a little bit of risk with surgery, um, it's riskier really not to have surgery. So, who's at increased risk for surgery? And this is any surgery, whether it's your gallbladder, a knee operation, or even your tonsils. You're at higher risk if you have 5 medical problems or more. If your BMI is over 50, you're a little higher risk patient. Older patients are higher risk than younger patients. Men are always a little higher risk than women because they just don't heal as fast. Diabetics don't heal as well either, and so they're a higher risk patient. People who have had previous blood clots are also higher risk, but the entire time you're in the hospital, I will give you a blood thinner so we help prevent that. Plus, you'll have some squeezers on your legs, and you'll be told to get up and walk around day of surgery because surgery is really not that painful. And then smokers. Smokers are high risk for having a problem, and that's why I ask you to quit smoking before surgery. So here is the major benefit of this operation. It is great to lose weight and feel better and be able to run around with your kids and grandkids, but one of the major other benefits is this. This is a patient who had a gastric bypass. These are all the medications he was taking the day of surgery. This is his 1-year follow-up, and he wasn't having to take any of those medications. He was off all of them. We've seen this in study after study. Here is a study by the Journal of American Medical Association, and what it shows is diabetes resolved 70 to 80% of the time. Hyperlipidemia or high cholesterol resolved 65 to 75% of the time. Hypertension resolved 50 to 75% of the time, and sleep apnea resolved 85 to 95% of the time. Here's another study that was done, and what you can see, a lot of the same results with great resolution. Throw away your pills, get back to normal life. What also noticed is 95% of patients said their quality of life improved after surgery. Weight does stay off with proper diet and exercise. Once again, there have been multiple studies that show this. So where do we go from here? Well, the next thing to do is come to clinic. Bring all of the information you can, fill out all the paperwork you can, and when you get there, we'll discuss what's best for you. One of the things I ask you to do is sign the agreement to comply with therapy. That means you'll take the vitamins and supplements as directed, that you will follow the guidelines of the pre and post-operative diet, that you will exercise on a regular basis. You will not get pregnant for at least 2 years after surgery. You will quit smoking 2 months before surgery and remain smoke-free for the rest of your life. And you will follow up with me at 2 weeks, 3 months, 6 months, and 12 months, and then at least every year thereafter, making sure that your vitamin levels are correct. Everybody has to see the psychologist. That's just to make sure that you are ready and your mind is ready for the major life change you're about to undergo. And everybody sees a nutritionist, which she will talk about how your life is going to change and how you're going to eat after. So you're ready and you're repaired for the new life to come. Surgery is a tool. It's an excellent tool. You must use it correctly, but it will work, and we are glad to help you. If you have any questions, please give us a call. We look forward to seeing you in the office. Call today and get an appointment. I'd be glad to see you and talk to you more about this exciting opportunity for you.